All right, good afternoon. I think we'll go ahead and get started. Can you just nod if you're hearing me? Okay, all right. As long as somebody is, and I know everybody is. Thank you. So this is our first Zoom conference and we're a little new to this. Typically we're on the receiving end of many Zoom meetings this past year, but it's our first one that we're doing ourselves. So if we have any IT difficulties, I apologize in advance, but we've done many test runs to make sure that this goes as smoothly as possible. For those of you that don't know, my name is Lori McIntyre. I'm the administrator of Hanover Hill. I have with me today Allison Lee, who's the assistant administrator, Laura Gallagher, who's the director of nursing, and Holly Lansdale, who's our customer relations director. And joining us in just a few minutes will be our guest speakers, Dr. Athar and Dr. Mills. Today, as we had talked about, we're going to discuss the COVID-19 vaccine as well as coping in the midst of uncertainty. As probably everybody knows, this week marked the 1-year anniversary of the first case of COVID in New Hampshire. Obviously, since that time, we've adapted to changes in long-term care that I don't think any of us ever would have thought imaginable. We've learned more about the virus, how it spreads, how to prevent it, how to treat it. And these were all put into practice when we had our last outbreak in November. That included 21 residents and no deaths. We also now have access to the monoclonal antibodies, which is new, and those can be used to treat persons who are at risk to progressing with more severe symptoms, and those would be directed by the physician. So that is something new that's now available to long-term care providers. Since our last outbreak, we've had 3 vaccine clinics that were allowed by the Federal Long-Term Care Pharmacy Partnership Program. And now the state, through the Department of Health and Human Services, is working to develop a program where nursing homes will have access to vaccines to distribute to new admissions. We really believe that the vaccine is the biggest tool that we have right now in allowing us to safely return to some sort of normal, but it does remain voluntary for both residents and staff. I know that's been a big question from family members as of late. We do provide encouragement, education, but it's ultimately their right to receive it or to refuse the vaccine. A little bit of statistics, because I think it's always helpful to help put it into perspective. In an article published on February 1st by the CDC, it indicated that 77.8% of residents and 37.5% of staff members at skilled nursing facilities chose to take the vaccine within the first month. At Hanover Hill, by the conclusion of our 3rd vaccine clinic, which was held on February 14th, we had 95% of residents who had received at least the first Pfizer shot, and we had 75% of staff receive the vaccine. Obviously, these numbers have changed since our last clinic, which was a couple of weeks ago, and will constantly vary as we receive new admissions and new staff. We do not disclose who has received the vaccine. We don't discriminate based on roommates, attending activities, or other events based on vaccination status. Currently, per the communication that went out on Friday, we have 2 active resident cases of COVID-19 with skilled patients that are on isolation. As these residents were previously on quarantine and did have a hospital admission, it did not put the facility into response testing or outbreak status. As many have asked and were able to share some limited information, these patients had not received the vaccine as they were new admissions, and they have had very mild symptoms for which obviously we're very thankful for their health right now. Staff testing remains based on county positivity rates, with our last testing date of this Tuesday. Today, we received those results and all staff continue to be negative. As CMS reports this week, we have a positivity rate of 12.3%. So today we held our second weekly staff testing event. We did participate in yesterday's Department of Health and Human Services weekly call, and it was discussed that there is potentially a large discrepancy in the New Hampshire website positivity rates and the CMS positivity rates. However, we were told to await further guidance if CMS, which as you know is our federal regulatory agency, will allow us to use the state numbers. If that's the case, and as soon as we get clarification, we'll be able to get that information out to family members immediately, because that will affect visitation status as well as our own staff testing status. Our number one goal remains to provide the safest possible environment for our residents and staff. Certainly, I think we can all agree there's nothing that we want more than to return to normal, open our doors, and welcome everybody back into the facility. It's been a very long year. Indoor visitation is still not allowed until county positivity rates dip below 10%. Which we anticipate very shortly, and know that we have a plan in place to resume these and schedule them as we have done in the past when those rates were below 10%, and we're able to accommodate them in a safe, socially distanced manner. There are instances in which compassionate visits are allowed, and we do encourage family members to speak with the nurse manager, social services, or I'm happy to assist in scheduling those as well. Compassionate visits are still scheduled. They're performed in a common space where social distance can occur and where visitors do not walk through resident hallways. Obviously, extenuating circumstances are involved for those where compassionate visits need to be at the bedside. And that's, something that we take into consideration and make available. I think that's the most of the information that I wanted to be able to share. I know that today's real purpose was to provide an educational forum, but I know with our most recent developments, I wanted to get that information out. I would like to turn it over to Laura Gallagher, who's the Director of Nursing, has led the clinical department through this pandemic, has done an amazing job of overcoming challenges and remaining focused on making sure that the best clinical care remains at the bedside. If you have specific questions, please type them in the chat. They are going to our moderator. We are able to distribute them to the speakers. So if they're pertinent to the speakers, we will address them. If they are individualized, we can address them on an individual basis, or if there's a common theme, we'll look to incorporate them in our next family communications. So thank you again for joining us, and I am going to sort of hand this to Laura.
All right. All right, thank you, Lori. So thank you everybody for joining us today. I think we have two great speakers to talk about very important things. Today we'll start off with Dr. Athar. Dr. Athar is our medical director here at the facility, but she is also the medical director for Elliott Senior Health. And we have worked with Dr. Athar for almost 6 years now, and we're very fortunate to be able to have her during this year, and she was able to be inside the facility with us. Day in and day out, helping to treat everybody and make sure everybody was getting the care that they needed. So we are very thankful to have had Dr. Athar, and I will have her start off today.
Hi, everybody. We're sitting in the same room, so there's a little bit of an echo.
There you go.
All right, very good. Welcome. Thank you all for coming. I really appreciate this opportunity to have a chat with everybody and kind of go over what the thought process is by the, sorry, something just popped up on my screen. to have this opportunity to talk about the vaccination itself. I appreciate Dr. Mills for joining us today. We always appreciate his help with our patients and him providing us his expertise today as well. So, the question, I mean, honestly, there's so much out there on social media and the news. I feel like a lot of people are very well equipped with quite a bit of information. However, with this information overload that we have from the media, from the news, it kind of gets difficult to differentiate what is important and what's not. So I'm hoping that I'd be able to talk to you guys about some of the things and kind of clarify why we need the vaccination, who should get it, and what we're trying to achieve here at the nursing home with certain restrictions, etc., that we have in place. I know that there have been some concerns from family members, and Lori and Laura were great enough to forward me some of the concerns. So hopefully I'll address those in the talk today. So bear with me as I proceed with a little bit of information about the vaccination itself and COVID. So as you are all aware, there are 3 vaccinations. And again, I kind of feel like I'm repeating a fact that is well known. We're very lucky recently that the 3rd vaccination is available to us through Johnson & Johnson. I kind of feel like I want to reiterate that we are very fortunate here in the US that we have 3 of these vaccinations, whereas countries in the world, other countries, do not even have access to even one of them. So we're kind of fortunate that the vaccinations that are available to us are the ones that have good efficacy, at least. A little bit about COVID-19 itself. Like Lori mentioned, we didn't know very much about the disease last year. I can tell you myself, in March, I was at loose ends, really didn't know much about the disease, didn't know what to do for it, how to help our patients through it. However, over the course of the past year, we've obviously gained a lot more experience. There's been a lot of data that we've received across the country that has helped us make decisions about medical care for people who develop COVID-19. What I do want to mention is, these are things that are well known. The news will update you about the number of cases, but we need to sit back and think. The news mentions that there are more than 28 million cases in this country. That's a huge number. It's not something to be taken lightly. This is an extremely contagious disease. It is an mRNA virus, so it will mutate. You will hear about all the scary stuff on the news about how there are variants out there and they're mutating. But the fact of the matter is, any virus that is an mRNA virus will mutate. That is a natural, history of any mRNA virus. So it's no surprise to us that this virus is also mutating. So when people ask me, well, it's mutating, I'm worried, will the vaccination have any effect? I try to explain to them that, these are things that in the medical profession you already hear of, but people are listening to this in real time over news. So it is causing a lot more panic than it would in the normal setting, just because as medical providers, we are already aware that these viruses mutate. So the reason why COVID is such a big deal is not only is it contagious and causing disease, it's causing a lot of death. I know for a fact that the cases that we had back in March of last year were far more severe, enough to cause a lot of deaths, as opposed to the variant that we had in December. So it has mutated, certainly. It is more contagious, but not as deadly. Maybe there are other factors, but now we know more about the disease itself, so we are able to treat it better. There's a lot of factors. We don't know what is actually helping, but certainly the variation and the virus itself is causing a lot of changes. Symptoms were different as well. So, as the disease, as time goes by, we'll learn that a lot of changes are going to happen. We'll just have to adapt based on that. And that is what I want to explain today. The key thing today would be to adapt. There are going to be changes. You will say, well, you said something different 6 months ago, but now you're saying something different. The reason is, again, because of the changes that are happening with the disease itself, there will be changes in a lot of policies and procedures. And as we learn more about the disease, we are going to be making more changes. So what I'm telling you today is based off of facts that today are current. Okay. So if something changes in the future, hopefully we'll let you know. Again, this disease can affect any age group, right? But it will cause a more severe infection in someone above the age of 65. It'll also cause a more severe disease in someone who's a long-term care resident or who's got chronic medical conditions. Now, when I say severe disease, I actually mean where they could potentially die from it or could end up in the ICU. So certainly, that's why everything we do in this facility is to make sure that our residents are do not end up with severe disease. However, I will tell you this. We are going to constantly hear about COVID cases popping up. This is here to stay. It's not going away. And I know there were concerns that, oh, now you've got the disease in the facility again. But I do want to explain, unfortunately, COVID in the United States is going to end up being endemic, which means that even though you won't have huge, eventually, hopefully, you won't have huge number of cases, you will have cases that will pop up in the future that will be intermittent. Again, that's somewhere in the future, hopefully when everybody gets vaccinated. But for now, we are noticing that post-holiday and post-election, there was a rise in the number of cases. We were trending down and now we're starting to go back up again a little bit. So, I think that with the vaccination, if we are able to get a lot more people vaccinated, we'll be able to see a better trend, and hopefully it'll become endemic and maybe eventually just peter out to a common cold kind of a disease. But let's see how things turn out with that. So now the biggest concern with COVID is, okay, people are going to die. That's our huge concern. But what people don't talk about is the long-term disability that can happen with COVID infection. So for people who do recover from COVID-19 infection, there is potential long-term effects that can happen. And so, those can be debilitating to the patients themselves. Right now, we're trying to collect the data. We're trying to figure out how much, how significant it is and how it affects the quality of life in our long-term residents. But that's information that we'll get in the long term. But again, the reason why I mention all of these things is because I want you to know, yes, people could survive the COVID-19 infection itself, but there is a possibility they'll end up with long-term complications or long-term disability from the virus itself. And not only that, there are certain studies that are actually showing, there's a drop in quality of life at least 8 weeks after a hospital discharge. So we'll be getting more, details as time goes on, but that's what we have for now. Now, coming on to the vaccination itself, I'm going to ask them to put up the picture that I have. This is the only slide I'll be showing today, and I want you to just bear with me as I walk through the slide. So this basically tells us about the 4 vaccinations that are most popular in the world. But the first 3 are the ones that are available in the US. The AstraZeneca is primarily in Europe and other parts of the world. But if you look at this slide itself, as you can see, the Pfizer and the Moderna are primarily mRNA vaccinations. What that, I'm sorry, it's fluctuating. Is that? Yeah, that's what it is.
We're not sure why that's
okay. All right. So the Pfizer and the Moderna are pretty similar vaccinations. I've had a lot of patients ask me, well, doctor, I'm a little curious about these vaccinations because they didn't have enough time to study the vaccinations itself. And I don't trust the fact that they did it in such a short duration and got the vaccine out right before election time, and et cetera, et cetera, et cetera. Primarily, I want to explain that the vaccination itself, the science that went behind making the vaccination is something that we've known of for years. That's not new science. The only thing that's new is that they have used that science to work against the COVID-19 vaccination itself. I do want to explain that these vaccinations that were prepared, even though they were studied over a very short duration of time, they used a large number of participants to create the data for this. If you had asked me back in October, doctor, should we get the vaccination? I would have said, I don't know. But having read the data myself, having reviewed the phase 3 trials and looked at, the randomized control trials, I feel like the vaccination, even though it was prepared within a short duration of time, I think they used a large cohort of people, a large number of people, which I feel like is a strong study, which shows us, what the benefit of the vaccination is, what the potential side effects are, and how it's going to affect us in the long run. So for the Pfizer, they used around more than 43,000 people. I feel like that's a large amount of people. For Moderna, there were approximately like 30,000. And for the Johnson and Johnson's, they actually did around a lot more than 43,000. I think there was 43,700 something. So that's a large number of people that volunteered for the study, which tells us that, it wasn't a short, quick study that was done just to get, an appeasement from people, or politically just to get people the vaccination. But I kind of feel like they really worked hard on getting a large number of participants, and the data itself is very solid because of that. Now, I think a lot of you already know about, the Pfizer vaccination, the Moderna vaccination. Primarily, there are 2 shots that are given 21 or 28 days apart. And as you can see on the screen, the Pfizer is 2 doses 3 weeks apart, and the Moderna is 2 doses 4 weeks apart. The Johnson and Johnson is a little different. It is not the same protein that they're using for the Moderna or the Pfizer. However, it's different, but it's not worse. So I've had patients that said, oh, I don't want the Johnson and Johnson just because I feel it's not as good as the others. Well, okay, but I'll explain to you why I would take whatever is available. At the end of the day, we're not getting an option on what vaccination we can get. So I think any vaccination is better than nothing. The Johnson and Johnson, the benefit of that is that it's only 1 dose, whereas the others are 2 doses. I'm not going to talk about the AstraZeneca because that's not available in the US right now anyways. But that's available on the screen if anyone has an interest in learning about it. And then some people said to me, well, the Johnson and Johnson was an emergency use authorization. So I'm not sure I want to use the Johnsons. I want to get the Johnson and Johnson. Well, they're all emergency use authorization. That's just the, the procedure for getting the vaccinations out before they could administer it to the general public. And that, helped get it out sooner rather than later. If you look at the 4th line, it tells you the disease prevention in the trial itself. If you notice, the disease prevention is 95% in Pfizer, 95% in Moderna, and it's 66% in Johnson's. Again, that just means that, if you get the vaccination, you could still get COVID-19, but there's a 95% chance that it's going to prevent it. Whereas in Johnson and Johnson's, they'll prevent it by 66%. Now, people look at that and think, oh, that means Johnson and Johnson is not that good. However, if you look at the line below that, it shows you the hospitalizations and death prevention that happens with the Pfizer, Moderna, and Johnson. That is the key line that we need to look at. That tells us that 100% of the times, these vaccinations are going to prevent you from getting severe disease, which means it's going to prevent death and ICU admissions. All right, and hopefully the long-term effects of the COVID-19 will also be taken care of. The major difference I feel like in the vaccination is just the storage, which is why it's hard to have availability of the Pfizer, in general public. The state is administering it. It has to be frozen below a certain temperature, and that's, it's hard to do that in your doctor's offices, etc. So the good thing about the Johnson & Johnson is that you don't have to worry about the refrigeration. Now you ask, well, how is it important? Whether how it's stored. Well, number one, it's hard to get the storage done if you have, in certain facilities, and that's how the availability will be affected. But on the other hand, it also will affect the vaccination if it's not stored properly. So you could potentially get the shot, but if it's not stored properly, then you might not have the effect of the vaccination as well as you would want to. Now, again, these vaccinations pretty much are to be recommended for people above the age of 16 or 18 years of age. I think Pfizer is above 16 years of age, and the Janssen & Janssen, Moderna are above 18 years of age. So the question now as well, doctor, if it's only preventing the disease to a certain degree, even though it's helping with hospitalization and death prevention, then why should we get the vaccination? Because it's not 100% getting rid of the disease itself, right? It's not preventing it completely, and it's not, it might still cause us to get COVID. Well, one thing that I talked about was certainly it decreases the severity of the disease. So say I get the COVID-19 vaccination and I get exposed to someone who has COVID. If I get the virus, then the severity of the disease will be less. I might have mild cold-like symptoms, and I might not even develop a severe enough infection where it would get tested. However, one of the big reasons why we want people to get the COVID-19 vaccination, and which is why we're having me present, is because I want to encourage family members and people, and I would encourage you to reach out to people that you know to get the vaccination, because number one, you're decreasing the spread, certainly, but then people say, well, you could still be a carrier. Yeah, but if you get herd, and I'm sure you've heard of this term, if you get herd immunity, which means that majority of the population is vaccinated, then your carrier state, the number of people who are carrying the disease will go down. I was reading the data, and it said you have to have the threshold for herd immunity to be able to get that would be if around 50 to 65% of the population in the US got vaccinated. The last time they checked that was like December, and of course, not that many people were vaccinated at that time, but at that time there were only 3 to 24% that were vaccinated. So that's a pretty low number. So we're hoping that we can encourage a large number of people to get vaccinated so that they could develop herd immunity, and hopefully we could be done with this disease just the way back in the old days we got rid of smallpox, the same way we'd be able to get rid of COVID-19. But you say, well, why can't you then just force everybody to get it? Force all your residents to get it, force all your staff to get it. Unfortunately, fortunately, we live in America, and so we can't force anyone to do anything, right? We're kind of, the government tells us that you cannot differentiate between people who are vaccinated versus not vaccinated. Now, I would love to be able to, make it mandatory for everyone to get it, but, I unfortunately, legally, I cannot make that choice for anybody. We are not allowed to force anyone to get the vaccination, no matter how much we would want it to be. That has to come from the government. So maybe you all need to send a letter to the governor and ask him to, mandate it for everybody to get the vaccination. But I doubt that, since they can't mandate the face mask out in public, I don't think they'll be able to mandate getting vaccinations for everybody. But that unfortunately is not our choice. As a facility, we cannot mandate it. It will be considered illegal for us to have it forced on anyone, or for us to let anyone go just because they're not willing to get vaccinated. So I know there have been concerns where family members have reached out and said, well, why can't you make it mandatory? Unfortunately, legally, we cannot make it such unless the government mandates it. So that's, hopefully that will answer your question on why we can't mandate it. However, I do want to let you know that even though we cannot force our staff or our residents to get vaccinated, we are having them wear PPE. Right now, as Lori mentioned, the community spread is higher, so we are getting everybody tested twice a week. I know that people are concerned, well, where is the COVID coming from in your facility? I will tell you right now, at this point, it's not coming from the staff, okay? As Lori mentioned, the cases that we had were from the community setting. So they did come from, there are cases in the hospital, and so patients will get COVID through their facilities to the hospital facilities or from the community setting. Unfortunately, we can't prevent that. We cannot prevent people from getting the medical care that they need. However, we are being very strict about the policies and protocols that we're putting in place. Anyone that is coming from the hospital who has not had COVID or not been vaccinated, they actually get put in quarantine for 14 days. So the reason why we caught these 2 cases for COVID is, firstly, we are testing immediately if someone comes with any sort of symptoms that might be COVID related. Secondly, we are making sure that anyone that's coming from outside who could potentially be a carrier is quarantined. So right now, we do not have a COVID outbreak in any of our long-term cases, in any of our long-term units, or in any of our long-term residents, or the staff either. I mean, I'll be honest with you, when a patient comes in from outside, we have to worry about our staff as well. So they're all wearing the appropriate PPE when they are going in to see these patients that are in quarantine. I will tell you this about myself. When I have a patient that comes from the hospital that I need to see, I start off on the other units first. I see those patients, and then I make my way at the end of the day to see the patients who are coming from the hospital. Of course, if it's an emergency, that's a different thing, but I try not to go back to the same patients on the other units after I've seen someone who has come from the hospital. We are doing things on our end to make sure that there is no spread of COVID from the quarantine patients to the other end. Plus, the amount of PPE I wear, I have like permanent marks on my face. I do want to let you know that on our end, we are making sure that we take the appropriate precautions so that anyone that's coming from outside does not spread it to the patients in our long-term care units. Now, having said that, we can't prevent it 100% because, again, it is a very contagious disease. Luckily, most of our residents have been vaccinated. I have a feeling this is something we're going to have to live with for a long period of time. So you will hear on and off about a case here and there. And because we have to remain transparent, you will be getting communications about a COVID patient or not. And I think that's great. I would like to know if my parent was living in a facility where they had a COVID case. But that does not mean that we are in outbreak status. Again, in December, when we had our COVID outbreak, at that time, we did not have that many patients that were positive. And when they were, we did isolate them to prevent further spread. I was pretty proud of the facility itself in the way they had made sure that we could contain it as much as possible. So, I mean, I'm sure you guys had gotten communication. Our numbers were not that high. So I was very proud of that. I mean, it was hard. It is a contagious disease, so it's hard to completely prevent the COVID from spreading, but we were very lucky that not many patients contracted the disease. The other thing is that, people are saying, well, when can we see our family member? When will you allow it? I do want to clarify. If it was up to me, things would be a whole lot different, but we are mandated by the state to make decisions about these things. So like, visitations and dining services and social visits, etc. That is not in our hands. As much as I would like my patients to be able to sit in the dining area, because I kind of feel like that's very important for their mental well-being, to be able to go back to the way things were before. Unfortunately, this is something that is being mandated by the Center of Medicare Services. So CMS is the one that decided, the state decides. We are not able to make those decisions independently. So I don't want anyone to think that we are going out of our way, keeping everybody, in the rooms and not allowing them outside just because that's our personal choice. It is not. It is what the state has asked us to do. And then the question is, well, why do you let these patients come in from outside who might potentially be carrying the disease? Well, you can't deny care to people who need it. Unfortunately, when we go into outbreak status, we have to limit, we can't allow admissions at that time. And I will tell you this, there have been so many times when multiple facilities were in COVID outbreak status, and there were so many patients who were not able to access the healthcare that they needed. And unfortunately, we cannot deprive them of the services that they need. So what we've done on our end is contain them in one unit so that if they are coming from outside, they are not mingling with our long-term residents. They are being limited. They're being kept in quarantine for 14 days. If they've been vaccinated or if they have had COVID-19, then they still remain on that unit. They might not have the same, contact precautions or droplet precautions others, but we still make precautions in that unit. So again, you might still hear about cases here and there. Doesn't mean we're in outbreak status. So that's again, I get it. If my parents were in a facility, I'd be worried about that too, that, oh, they have more cases, but understand that it is being limited to certain units. And that's how we did it back in March of last year and December, where we limited it to certain units so that it did not spread to the others. All right, there were a couple more other things I wanted to talk about. Again, people say, well, don't take admissions. Well, the other thing is we have long-term residents here in the facility who do get sent out to the hospital for various medical concerns. So there is no way to just lock down the facility and prevent people from going in and out. The other thing is patients are going to their doctor's appointments. If they're going to their doctor's appointments, we can't stop them from doing that. Certainly, if it is a visit that can be done via video, we try to do it via video. But if it is an absolutely necessary visit, they are going out to their doctor's appointments. So you're going to say, well, you can't contain them. You can't send them. You can't stop people from coming into the facility. How are we going to prevent the COVID from coming into the building? Well, we can't 100% prevent the COVID from coming into the building. What we can do is the patients that are here, the long-term residents that are here, we make sure that they are protected. And the way they can be protected is by being given the vaccination. Like I said, we've got a really good number of people that have already gotten vaccinated. So 95% is amazing. I feel like we were lucky. I wish the ones that have not gotten it so far will be able to get it. We are trying to get it through the state. They're trying to figure out their clinics and how to administer it. So hopefully when that gets done, we'll be able to, move forward. I do want to say though that some of the patients or some of the residents who have not gotten it is not because they didn't decide to do it. Some of them might have medical issues that prevented us from being able to give them the vaccination. So they might have been willing, but we were not able to give it to them just because at that time certain medical issues were going on. And the same thing goes for the staff. It might be because of a medical issue that's going on that they were not unable to get the vaccination. But we are making sure that they're wearing the PPE. So God forbid they catch it from the community, they're not passing on to the residents. In the next few months or next 6 months or in the next year, we will figure out how effective these vaccinations are. Right now, so far, it looks like they're really good. The efficacy is great. We're having, we haven't seen any patients of ours who've been vaccinated who got the COVID, which knock wood is great. That might just be because we're taking very good precautions and they're not being exposed to anyone with COVID. On the other hand, the other thing could be that, the vaccine is working and I think it could be a combination of things. I think we also had compared to other facilities, we had quite a number of staff sign up as well. So I'm kind of happy that happened. Again, unfortunately, I can't force everybody to get it, no matter how much I'd want to. The other thing is that, when the governor says, okay, you can allow family members to come in to meet the residents. I would love for my residents to be able to meet their family members, but I will tell you right now, I am very scared. The reason why I'm scared is I understand that the need for meeting your loved one is important. I mean, I haven't seen my parents since last year. So I know it's been more than a year and it's difficult. But I'm scared because I can only control what's in my facility. And even that, I cannot control it 100%. I can certainly encourage people to get the vaccination in the facility. I can encourage the staff, the residents, but I cannot force their family members to get the vaccination, which is why I agreed to the presentation today. You are going to be coming in at some point to meet your loved one. I would strongly encourage you to get the vaccination because you will not only be doing your family member and loved one a favor, you will also be doing a favor to all the other residents who are in their vicinity. You as if the majority number of people of us get the vaccination, we will be able to get this thing under control. I know a lot of people are scared about the vaccination. I got it myself. I can't wait for my parents to get it. But and we are very fortunate we have the vaccinations that are available to us in the US. But please get the vaccination, because you will not only be helping your loved one, but you'll also be helping other residents here in the facility. And certainly it'll help me sleep better. So I would really appreciate that. Because I will tell you this, when we have cases, me and Shannon and I are super involved, and we get busier. So we want to keep the COVID out of the facility. So I think that's pretty much it. I would request that you please get the vaccination. Please talk to your doctors if you have questions or concerns. You will be helping us. I know that people are wondering when the visitations will start. We do not know. Again, that is going to be based on when the governor decides to open up the facilities. Right now, the spread is around 12%. So I guess it's less than 10% when that happens. But I would just I want to tell you that the plain surgical mask is only meant to be effective outside 6 feet apart. Indoors, it is not that effective. So make sure you guys are getting vaccinated so we reduce the spread and we can keep our residents safe. All right. I think that's pretty much it from me. I hope I didn't go on for so long, but I probably did. Thank you very much, everybody. And I'll pass it on to Laura.
All right, well, thank you very much for that. Our second part of our presentation today is with Dr. Mills. Dr. Mills is the medical director for Elliott Hospital's Palliative and Hospice program, and we've been working with Dr. Mills for close to 7 years now. He's always rounded in our facility, and since COVID, he has done it virtually. I've been able to round with him weekly, and we go see all of his patients together. His specialty enables him to talk with the patient to ensure that their goals align with the treatment that they're receiving. So he spends a lot of time talking to them about their feelings, and especially this past year during COVID and isolation and how they're doing. So he is able to engage with them and talk about how they're feeling and strategies to cope with everything going on in the pandemic. So this is a great opportunity to have Dr. Mills talk about what his experience and share what he's found over the last year. And he has entitled it Coping in the Midst of Uncertainty. So Dr. Mills, this is time for you.
Thank you, Laura, and thank you everybody for joining. I think the most pertinent information Dr. Athar already has shared. These are the hot button issues that any family member would want to be most concerned about. That is, when and how and what are the decisions being made about the vaccines, et cetera. So my talk is a little bit more on the, I would call it the touchy-feely side of it that all of us have had. So if we put up the first slide, is that okay, Allison? Can you put up the first slide? That looks, there you go. Here we go. I love these. Okay, that's okay. Let's just see here. Okay, not that one. No, not that one either. Slides of my vacation. Okay. Okay. Do you have those slides that are my slides by chance? Okay. Okay. I'll give this 10 seconds. Anyway, I'll give a disclaimer as we're waiting for the slides to come up. You might say, well, what is this guy's expertise? Why is he talking to us? Who cares what he thinks? And in truth, the fact is, everybody on this phone call, me included, we're all suffering the events and changes of this last year. And so palliative care, my specialty, which is very much about, Laura said it, it's very much about trying to understand people's values and what brings them quality of life. Palliative care is uniquely positioned to think about the COVID pandemic in a way that's not just about the science of the virus and the response to the virus, but it really about what has happened emotionally to all of us in the face of it. And certainly from the folks on this on this Zoom conference, how they've had to suffer in terms of the separation from loved ones, and in some cases how they not only had to suffer but had to suffer permanent loss. That is, people who have died during the course of this, and then the families have been separated even toward the end of a lifetime. Very very hard. So I sort of premised my talk. I actually had given this talk and parts of it to staff too, because we're all suffering. And I premised my talk by an example in my own life. I used to, when I was a smaller guy and younger guy, and didn't have so much arthritis in my back and my knees, I used to run marathons. And I was one time running a marathon. It was the first time marathon out in Disney World in Disneyland in California. And so they had measured out the marathon loop, and it was a 2-loop marathon. And essentially, oh, very good, excellent. Essentially, what they did was they measured out 2 13.1-mile loops, and you had to do it twice. And then when you came back, you'd finish up at Disneyland, the park. And so, you know, running a marathon is really hard because you get sort of fatigued in the brain. You have to sort of keep encouraging yourself to keep going. And what happened was that they had mismeasured the length of the race. So just as you thought you're coming to the end of the race, you can see the park, you're getting closer and closer, and you think, I've only got a mile left to do, and I'm almost there. Suddenly you see a guy standing outside the park waving you on. He was waving you to a new loop. And I can't tell you how discouraging it is if you're getting up to 24, 25 miles of running, and somebody suddenly is telling you, no, you're not through yet. You've got another 2-mile loop to do. And that's exactly what they did. They looped us out past another place. It felt like we just wanted to give up. And in some ways, I think back to that experience because how I felt personally through COVID is very, very much that same feeling of it just goes on and on and on. Even now, as we're facing some very good news, the things that Dr. Althor pointed out about the vaccine, incredibly good news, but it always is tainted with the next conditional. And you just heard some of the conditionals. When can I get in actually to see my loved one? All this is good. We're gonna have vaccines, but when does the metal hit the floor, the rubber hit the road here? When do I get in? And it keeps, oh, well, not quite yet, or maybe you can get together, but you can't get, it's all these conditionals. Anyway, so that's what I think I premised my talk on that feeling, because I think there's nobody on this phone call, staff, facility related, the doctors, the nurses, the families, and the patients who aren't feeling it. So I want to reflect on this. Next slide. And that this goes through all the reasons for the cope, but I think if I have anything, I hope at the end of this, hopefully brief talk, maybe you have just a few more mechanisms of coping. I don't pretend to have the magic and all the solutions for everything that you're all facing. Each person is facing some of the trauma distinctively and uniquely on their own, but I think there are some common tools at hand, and certainly palliative care as a specialty tries to delve into that to help people cope. I know in my rounding with Laura at your facility and rounding at other facilities, a lot of my time now is a little bit about the medicine, but an awful lot about the emotions of what people and patients are feeling. So let's go next. So what do we know for certain? Well, masks do work, and just continuing to use masks fastidiously for the foreseeable future makes sense. It limits the risk of continued spread and escalations in the next surge. And by the way, that meets all our goals, because what we want to do is we want to get back together. So if we're not using masks or anything that works that helps to mitigate this, then we're just prolonging the misery of our present situation. Outdoor spaces are clearly better than indoor spaces. The smaller the group you're in, the better it is, preferably less than 10. Okay, all these rules, you don't need it from me, Dr. Fauci and Dr. Sanjay Gupta. You can hear this any day of the week on the TV. In the mRNA, as Dr. Althor is pointing out, is an effective vaccine, and and how contagious the whole issue of and the rollout of what the mRNA will have in terms of its scope of the socialization that occurs after the vaccine, that's still sort of in the offing. We know it definitely affects the rate of severity of illness, but the question really is, when will we get back to our normal lives? Okay, so let's and I, like you, I'm trying to understand this, and so I'm not quite as fastidious as Dr. Athar about looking at all the science. I'm watching Dr. Gupta and Dr. Fauci on the TV, trying to cull from their words. Or Dr. Michael Osterholm, here's another one. I'm listening. But what does he actually say? What's the subtlety of it? Anyway, so next slide. Things that just don't make much sense. Okay, and so I'm just reflecting on this, just like any other human being. I'm listening, and we don't know if the vaccine, if you get the vaccine, does that stop you transmitting virus to others, even if it's protecting you? And the presumption is that we don't know that, therefore we're acting as if it could. You could have the vaccine and still have the potential to spread. We aren't certain how fully the vaccine protects against the new variant. We have a sense that it blunts it. It may not be as perfect, but it still seems that our expectation is maybe it's going to protect against severe illness. We're not certain that does it protect against the range of the illnesses that way, and we still don't know that. And of course, variants keep cropping up, and we don't know how much the community-rated spread now reflects the level of risk to certain settings. So, for example, everybody listening on the TV, you'll hear the whole thing about reopening schools, and then you'll hear about certain districts where it had a high rate of transmission in the environment, and yet the schools were safe and they'd been open for the last 6 months, or et cetera, et cetera. Confusing. It's almost impossible to be a reasonable mind and listen to all that and figure out, well, what does that mean? And we don't know whether repeat positive swab testing in people with the vaccine status means they're still actively infected. I mean, obviously they turn a test positive, but is it the same positivity? What does that mean? Clearly the people, what we have witnessed when people have had, I can say this from the facilities I've been in, when we have people who've been, had the infection or have had the vaccine and the infection before, and they quote unquote get now a new infection, they're clearly not as ill. We haven't had anybody who's, as Dr. Athar pointed out, nobody who's really been of the same ilk of what we saw early last March and April. And trying to listen to these experts really increases angst and uncertainty, because every day there's a subtle change. And of course, what's interesting is that the TV commentators, the people asking the questions, they have a vested interest too. I always listen to Alison Camerata in the morning on CNN, who's so desperate to have something so her family can get together. She keeps framing the questions in a way of, when can I have my family gathering again? She was very devastated about Christmas and et cetera, et cetera. So it's a natural human thing. It's not malevolent. It's just the natural things. Next slide. And of course, what we are clamoring for, everybody on this phone call, we're clamoring for normalcy. We want to go back to who we've been in our society. And there's no one. It's not the facility. It's not the staff. It's not the families. It's not the patients. There's no one who say, well, that other party is not really interested in that. That's just not true. Dr. Athar pointed out something that I think was very interesting. And guess what? When these cases crop up, it makes for added work burden. It's the last thing in the world you want to say, oh, well, what the heck, let's get some more COVID cases in here to keep us busy. Absolutely not. It wouldn't be completely antithetical. And of course, in terms of nursing homes, what you all are suffering in the intensity, it's so poignant, is the absence of seeing people you love and actually witnessing how they've changed physically in the course of this year, and feeling so helpless in the face of that change. Next slide. And this is a core idea. We can't really find normalcy if we don't find a place to put the energy in our heads of our mental health. How do we cope with this? If we are tearing at our insides endlessly about what we're failing to do toward each other or toward our loved ones in facilities, that there'll never be a normalcy when there are those disconnects. And I'm not blaming anybody for that feeling of angst. It's just that we have to figure out a way by which we can address ourselves to that too concurrently. that brings us to mental health, even in the face of things we cannot control the rate of change of, which is the COVID pandemic. Next slide. So I'm putting up a couple of articles just as reference points, just so you can see this issue about that this is a mental health crisis. There's a lot of reference to it. There's a huge literature on this, amazing literature that has cropped up during the course of this year of people coming to discover the issues of how seriously this has affected the mental well-being, not just of patients, but of families dealing with it. And you can see the focus on older adults, communities of risk, Black and Hispanic Americans, and healthcare workers. Next slide. And again, the psychological stress, so they did studies of internet searches, how many searches for these themes of anxiety, panic attack, insomnia, all rose during surges. And of course, that would be the case because people are desperate to figure out solutions of how can they cope in the face of this. Next slide. And this is phenomenal. This is a resident at Brigham and Women's Hospital in Boston wrote this article that I amazingly astute. I say that because I assume a young person in terms of their life experience, but her insights about the cascading strain of losses and change. Next slide. This is, I won't read all of this, but this is this poignant a statement about the realities that we spent. I think the second bullet, I feel unnerved by these challenges. She cites this poem, One Art by Elizabeth. The art of losing isn't hard to master. The small losses like door keys, my mother's watch, hour badly spent are no disaster. But the greater tragedies during these long months of COVID, our tally of losses has accumulated. We lost intimacy of holding hands. We lost our interrelationship with our own families. People who are in healthcare, when they go home at night, how they've had to separate themselves from their loved ones because of the role they play within institutions. This is so poignant in how she said it and so accurate. Next slide. And this is sampling of some things that I've heard during these, just a small percentage of what I've heard in these conversations that I've had with families and with patients. And so it will be varying voices here, some patients, some families. My son is angry with me. That's why he stopped coming to see me. That symptom is my mom showing her connection to family by concern for those that she's expressing it by taking it out the same symptom. I just gotta move that away 1 second. There we go. I should have taken mom home in February when I still had the opportunity. How much worse would it have been if she was at home compared to this? A patient saying, this is worse than a jail. They won't let me go out into the hall. My wife doesn't recognize me anymore. What good is FaceTime? My husband is dying. What good does it make it do to make a visit only when he's so far gone that he can't possibly know I'm there? If I come in, I'm sure she'll eat for me. I'd rather send them to the emergency room. At least I have a chance to see them there. Why can't I see my dad? I've already had COVID infection. Just a list, random list of some statements. All of those are real statements, and a ton of voices and commentary about all this from family side. But let me show you also what spiritually is happening on the provider side. Next slide. So this was a statement from the chief medical officer at Elliott we get these updates all the time, every day updates on the volume of patients and cases, the case in the state. I mean, it's every single day is a volume of occupancy around COVID. But he recognized that the vulnerability has heightened our sense of responsibility to our patients. While our resources of a hospital and a state are being strained, the juxtaposition of being emotionally and physically available for our patients while having less to offer them is unsettling. Let's think about that. The role of a provider, a clinical provider, is very much in the role of a giving. And here we are facing the situation of this virus, our incapacity to give to solve the problems of what our patients are facing. Every day we're accustomed to the idea of loss that is in the natural role of physicians and nurses and staff, that people do die, people evolve. But the sense in this is the frustration of what we've had to give has been a paucity of what we would want to give. And he goes on to note also in an overwhelmed system is different than a personal failure of duty. And he's reminding us as clinicians, your participation in the care of our community at any level during the pandemic is commendable and honestly heroic. Many work selflessly extra hours. I will say this not to just plug Laura, but and getting to know Laura through all these through all these visits on the screen. Every time we meet, we're talking about what challenge she's had to face that week because of some new standard or some new demand or some new event, like the 2 patients that came in with the COVID. Next slide. So between these 2 perspectives, so it's not like the families alone are suffering, the patients alone are suffering, the healthcare workers alone are suffering. We're all suffering. But between those perspectives, there's a common truth. The disease is the culprit. It's not you. I want you to remember that phrase. The disease is the culprit, not you. Because every family on this phone, the feeling of frustration is not only the absence of visitation, but the absence of an action that you feel is appropriate that by your loved ones. And if you had only done the right thing, or we're only doing the right thing right now, this would be a different situation. And that feeling is exactly the feeling that clinicians and staff feel too. But the truth behind it that we have to remember is that the disease is the culprit, not you. And how we all approach and interact with each other should be guided by some basic ethical principles. Next slide. Human dignity, right? We remember human dignity, remember there's a common good, respect for autonomy. Non-maleficence means don't do bad by people. Solidarity, equity, special concern for the vulnerable, and stewardship. And these get expressed through the next slide. Reasonableness, transparency, reciprocity, proportionality. The very fact we're having this Zoom, we all as a community, a sub-community, the people associated to the Hanover Hill as a facility, the very fact we're having a Zoom is reflective of the sense of wanting to be reasonable and transparent and help to build a reciprocity and proportionality response. The problem is, of course, that's the phrase underneath there, understanding that these values evolve definitionally as more is known and understood. So what is reasonable today, day 1, cannot be applicable to day 365. That is always hard. That's hard for families, that's hard for staff. So you can hear people clamoring and say, oh, there's the 12% transmission rate. Is that still a reasonable standard? And the governor came out and said, well, we're gonna open them all up. But the standard still exists and we haven't changed it based on the reality we're facing. So all those ethical precepts and these patterns of procedural values are ways that help to anchor all of us as we interact with each other, to help to steer us in a way that doesn't become destructive in our own interplay. Next slide. And behind this, we have to find a daily path to go forward. And this is a phenomenal article. If you have access to JAMA, or you can get access. Post-traumatic growth is a concept that's been around for a long time, but post-traumatic growth for organizations and individuals is a way to salvage your sanity and your mental health and your well-being in the face of the trauma of pandemic. Next slide. And post-traumatic growth is defined as positive psychological change experienced as a result of a struggle with highly challenging life circumstances, and through establishing perspectives for a new normal when the old normal is no longer an option. Post-traumatic growth develops following a physical or psychological trauma that is disruptive enough to affect the individual's perspectives and values, and it stimulates reassessment and rebuilding of psychological and philosophical beliefs and approach to living. It is correlative to post-traumatic stress disorder, because the two are opposite poles of the phenomena of our emotional response. In post-traumatic stress, we become trapped. We relive a trauma or a stress, we become trapped in that stress, and it becomes intrusive to every day. Post-traumatic growth allows us to find an energy that then doesn't allow us to be trapped, but rather to go outside of it to a new perspective, even in the face of the ongoing trauma. And we can be trained to predominate with post-traumatic growth over post-traumatic stress. Next slide. So these are some of the domains of post-traumatic growth. I didn't bother to define them fully. There's some slides that go along with this. But I will say in this context, so that you have it as you think about it, I'm going to give some examples of post-traumatic resourcefulness. Every single one of us on this phone call, staff, family, friends, clinicians, every single person on this phone call has the capacity, when they face their daily events of their life, be it how am I going to interact with my mom today who's at the nursing home, or what are my tasks in terms of clinical care today, every single one of us has to find an energy by which we then apply ourselves to that task of that day. And the question is, as we apply ourselves to that energy, the question is, what gives us the energy to do so? If you're feeling despair in the moment, let's say in the case of the clinician or the saying, I'm just going to trudge through this again, this is hopeless, COVID just keeps going, no matter what I do, it's just going down. You need to find a resource within your environment where the spirit of that resource is greater than the depression or the despair of the moment of the pandemic. And what I use as an example of this is every one of us, every single one person on this phone can think in their daily existence, somebody who you contacted today or yesterday, where you found an inspiration or a joy or an energy of that person in the moment of their life that superseded the depression of our existence. And the challenge that we all have is to be aware of and keep our radar up for those people, because from those people comes an energy that allows us then the salvation of doing better in our own moments. What's striking is sometimes we are the individual with that energy and that joy and that positivity, and then people are clamoring to us. I think the fact is that what we sell ourselves short sometimes in recognizing when our good sense of humor or when our capacity to have exchanged with our loved ones or our patients, when that moment has been a moment that actually superseded us in the moment of the exchange and was witnessed by more than us and actually brought strength and purpose to those around us. I am endlessly impressed by being witness to people's energies when they least know that energy is being demonstrated to those around us. And I can tell you, having gone into numerous nursing homes now in this last year, what I have witnessed individually has heartened me, has brought me energy to be able to continue to do what I'm doing. So if I can see it, and it takes an energy and an effort to do so, you too can see it. And that not only can you see it, but you can also figure out the moments in your own lives in which you become that source of energy for others. The very fact of doing, again, this talk, the fact we're exchanging, the fact that we're listening to each other means that we are searching for that energy. We're not searching to live in the post-traumatic stress disorder. We're looking to find growth out of this moment. I will give you a personal example. I'm big on travel in my life as I've gotten older. Old people like to travel. This obviously the last year and a half has all of the plans of trips have been canceled and all this other stuff. It's a trivial example, but nonetheless, so I realized that, and also my clinical work, I'm very much more at home. I'm doing one facility I go into, most of the other facilities on video. Everything about the core sense of my personal values and my sense of my identification has changed in the course of this year. And just as I was thinking about it, and especially in the context of post-traumatic growth, I was realizing, well, you know what? It makes me start to really appreciate my home a lot better. It makes me appreciate the environment that as I'm sitting here doing these visits, the beauty of my neighborhood, the beauty of the seasons changing, the fun with my dog. And then I recognized as the season came on, the spring came and the flowers came, that my backyard, my deck was just as phenomenal as anywhere I had traveled around the world in terms of its beauty. And I got a special new chair for myself. I put it out on the deck. And so a lot of my midday work was simply to stop in the middle of the day and to go out on the back of the deck and pretend that I was on board ship on the best deck of the ship alone. And I was enjoying the beauty that I saw. Now you might say, this person is clearly crazy, right? He's in a fantasy world. But that allowing myself to see something out of the abnormal to become a positive toward a new normal allowed me the strength then to be able to then exist and do my task. And I think it's a silly example, and it probably doesn't apply to most of you in a way, but there are elements of that experience that each of you on this phone need to reach inside of yourself and think, okay, I'm not seeing my parents, I'm witnessing their decline, but what is it that I am still seeing? I will say this, I think he's on the phone, so I won't mention by name, but one of the patient's sons who I spoke to within the last couple of weeks cited an example. I was telling him about a symptom his mom was having, and I was really concerned about this symptom. And instead of being devastated by the symptom, he recognized his mom's personality as coming to the fore of her concern for others outside of her, because that symptom was something that she was witnessing as she heard about things happening in her family. And so she was speaking to it in that context. And actually, first off, it lightened my load because I was very frightened something bad was happening to the patient. But secondly, the fact that he had that as a gift to give me is something, as an example, that I think we can all sort of bend ourselves to say, yeah, you know what? There are things I can share. Even as I'm helpless in the face of the COVID, I'm not truly helpless in my capacity to see something positive. And again, palliative care is not just Pollyannish. I don't want you to think, well, you just be smiling, happy, and all this. I'll use the vernacular. This all sucks. There's no doubt about it. It sucks for all of us. But what I want you to know that as a clinician and as a human being, I have concerns for you and what you're experiencing, just as I do for the patients, because I can witness it on a very personal level, that I too am suffering some of those losses. And I have to figure out how I'll have the strength to get over the losses, to bring something still good to the situation. And everyone on this phone has that power still. Okay, so thank you for listening.
Like the sun is coming inside the conference room. Thank you so much, Dr. Athar, Dr. Mills. The both of you have truly been invaluable during this past year. I think that we all recognize that we face many challenges. I'm very proud of the staff here at the facility who, for the past year, day in and day out, no matter what the obstacle, continues to remain committed and always has your loved one's best interest at heart. It hasn't been easy, and we are very much looking forward to returning to some sort of normal. We want to see you again. The residents want to see you. We want to get back to the vibrant, open community that we had here at the facility. And certainly we're doing our best to provide those activities. The activities department, the nursing staff, everybody has really come together to get creative in order to still have special events and still hold daily activities for the residents. But ultimately, our goal is to welcome you all back. So again, I hope that you found all of the information helpful. If you have questions, we did not really see anything in, I'm checking with Allison, but we didn't really see anything in the chat that was not already answered. Please reach out to me. We talked about visitation. I hope to have more clarification from the state on the positivity rates very soon. And then we will get back to offering that indoor visitation. Compassionate visitation has broadened. So please, if you are interested in a compassionate visit, please reach out to the nurse manager of your loved one's unit, the social worker, or myself. And we're all happy to assist you and sort of walk through what that process looks like. So again, if you have any questions following the meeting, we will look to do a weekly communication next week if there isn't any new developments this week. And we'll incorporate anything that's come our way since then. So please, you're welcome to email myself. It's administrator@hanoverhill.com. And again, it's Lori McIntyre, or you're also able, Holly Lansdale, our customer relations director, is customer service@hanoverhill.com. And both of us will be sure that we reply and incorporate those thoughts. So thank you. I hope you found all of this information really helpful. And certainly if we get positive feedback from this, our goal will be to continue these on a more regular basis. So thank you and have a good night, everybody.